Welcome to the award-winning Women in Healthcare Leadership podcast series brought to you by Medscape Education. Our mission is to educate, advocate, and inspire women in healthcare to lift as they rise. Each episode brings you voices of leaders who are breaking barriers and leading the way in advancing women's health. Join our global community of listeners as we hear from her. Ready to be part of the movement? Let's dive in.
In today's discussion, we're going to explore how we manage painful conditions such as migraine during pregnancy that is common but often under-recognized and that can significantly impact both mothers and their babies. We're going to talk about the challenges of treating migraine during pregnancy and the emerging role of neuromodulation and non-drug therapies as potential options to improve care and outcomes. So let's get started. Michelle, let's start with you. How did you get into this space and how did you find yourself today working in the field of migraine management?
So, as you stated, I have about 28 years of experience as an obstetrician gynecologist. And obviously, with that span of time, there's very few things at this point that we haven't seen during pregnancy. And migraines tends to be one of those things that I think is poorly understood in pregnancy. And there's also a lack of real experience in preventing them and, treating them. So I was recruited to, help with a study, that basically was looking at women, who are pregnant and experiencing migraines, and that's how, we were recruited to this study.
So, Jolene, how did you get into this field? Did you always know that you wanted to practice medicine and take care of women?
Well, first of all, thank you, Joanna, for having all of us here today. And it's actually funny you say that because when I think about my journey and desire to become a doctor, it actually started as a at a very young age. I wasn't born into a family of physicians. And in fact, I was the first and only doctor in my family. So that medical calling was purely a passion from inside. And I was determined to make the childhood dream become a reality. So after high school, I went to college at Penn State University pre med program, and then after graduating college, I did a research year in a basic science lab, and then ultimately I went to medical school at the University of Pittsburgh School of Medicine. But what's funny is that most people, when they go into medical school, don't know what they want to do. But for me, that decision became very clear when I was doing a college summer job, working for a stem cell company, actually collecting cord blood from placentas. And on one of my work shifts, I just have to tell the story because on one of my work shifts, there was an OBGYN who I'll never forget. He knew I wanted to go into medical school, so he asked if I wanted to observe a C section. And so I got to scrub in. And then I tell you, witnessing that baby coming into the world for the first time was like purely magical. And I remember leaving the OR, beaming with excitement. And then I called my parents and said, I want to be an OB. And they're like, first, let's get you to med school. And so that incredible experience really paved the way for me to dive deeper into women's health. And fast forward to my fourth year of medical school, was when I chose MFM as a elective rotation, and that's when I grasped that not every pregnancy is as straightforward or perfect as the one I witnessed in a college. And I found myself completely captivated by the challenging cases in MFM. And from there, it was a no brainer. MFM was the best of both worlds. You could treat mom and baby at the same time when they needed you the most. So after medical school, I completed my OBGYN residency and my MFM fellowship at Thomas Jefferson University in Philadelphia. And then I went on to practice MFM in a community hospital in New Jersey where I've been for 16 years. And this is a very busy clinical practice, so there was not much room for research. And then a few years ago, Michelle had reached out to me about this research opportunity in neuromodulation in pregnancy. And so when it came my way, I jumped onto that opportunity. But to be honest, I did not know much about neuromodulation when I was approached. I was only familiar with it with treatment in psychiatric diseases. On a personal level, my daughter suffers from severe debilitating OCD and depression. And so neuromodulation has been used in her treatment plan. And so I was so super excited to see how this neuromodulation could help my patients in pregnancy who suffer from migraines. And as a cherry on top, I was able to join this amazing team of doctors that are here with us today. So that's my story.
I love that. No, thank you so much for sharing that. It's so amazing how when you're doing research, you're also able to kind of help people in your family, and it just makes it that much more worthwhile. And so, and I think obviously there's a huge intersection here with how the brain works and applying neuromodulation. So I just want to give a little shout out. We have a neurologist in the house as well, Dr. Deena Kuruvilla. So I also wanted to introduce her to the podcast. And Deena, would love to learn about your career journey. What was it? Did you always know that you wanted to go into medicine, or how did that all happen for you?
Well, I'll start off by saying my background is Indian, South Asian Indian. And so we're given a choice growing up, right? It's like you become a doctor or an engineer, and that's pretty much it. I was like, okay, well, I'm not great at math. And so I went down the medicine pathway and haven't looked back since. I've always found the brain fascinating. I started off in neurology residency at Brown, did a fellowship at the Montefiore Headache Center because I wanted to treat people with different types of headache disorders, such as migraine. I went on to work at Yale for about 6 years under faculty and felt that I was very siloed in my specialty. So I was only seeing headache and neurology, and patients would ask me constantly, what do you know about the menopause I'm going through right now? What do you know about pregnancy? What do you know about all these other things I'm dealing with that are separate from headache? For that reason, 6 years ago, I opened up my own practice, the Brain Health Institute in Westport, so I could have more time with patients and customize things that matter to them. So in my practice now, I see mostly migraine is probably about 80% of people I see. I see other neurological conditions such as Alzheimer's, Parkinson's, back pain, neuropathy, but I love learning. I love reading. And so I have partnered with my local OBGYN colleagues, ENT docs, surgeons, everybody to work together in a multidisciplinary approach. And I think that's really what's special about what myself and Michelle and Jolene have is that we work together on a team and where we get perspectives from neurology, women's health, and beyond. So that's how I ended up here. Thank you for having me.
I guess it's natural you've gravitated towards having the majority of your patients with migraine headache, but tell us like why you feel this subject is important to you and also to the world to know more about.
Migraine it predominantly affects women in a 3-to-1 ratio when we're looking at migraine between women and men in the United States. It's one of the leading causes for disability. And over the years, I've observed so many things about migraine, specifically in pregnancy, perimenopause, and all of the different phases of a woman's life. And that is, if migraine is out of control, we see all the other medical conditions that people have go out of control as well, such as blood pressure, obesity, and beyond. All different types of medical conditions can go haywire in those situations. And so, for that reason, I like to not only look at migraine and focus on it, uh, because it's a disease in itself, but I really do see that we can help other comorbidities, other medical conditions by helping people with migraine. That's the first thing I'll say. The second thing I'll say is migraine is incredibly underdiagnosed. Joe, you don't know the number of people that come into the office and tell me that they have been diagnosed with sinusitis, have undergone 10 different sinus surgeries thinking they had sinus headaches, or folks who have been diagnosed with jaw problems, or people who have had neck surgeries and just have carried a wrong diagnosis for a really long time when they truly had a very treatable condition, which is migraine. So that's the other reason that this is so important to me.
Absolutely. I think you articulated that really well. And so I wanted to maybe turn it over to Michelle here to tell us what exactly is the impact of migraine on a pregnant woman. What does that look like in your practice?
So, I think it's important to understand that migraine is not just a headache, right? It's a complex disease process that can include a headache. Usually it's one sided, but not always. And it has associated symptoms like, nausea and vomiting, um, sensitivity to light, sensitivity to sound, sensitivity to smell, and all of these things can affect even a non pregnant woman, right? I mean, we have women who have menstrual migraines. I see this a lot where women are debilitated. When they're in that period of time leading up to their menstrual cycle. So it's incumbent on us to treat not just the headache, but the whole complex of issues that go along with it because they're losing productivity, right? They have a lot of time off from work when they're in pain like this, and they can't even look at the sun. If they're moms, they need help. This certainly is affecting them from a social standpoint because they're avoiding activities. And it definitely hurts their pocketbook as well. So I think it's important to understand that it's not just affecting women during pregnancy that's important, but even beyond. But specifically to pregnancy, there's a lot of crossover, right? Between symptoms that you have when you get your migraine and when you're pregnant, namely that nausea and vomiting. And if those things are not addressed adequately, then we have a situation where this pregnant mom to be may not be hydrating enough, right? Or she may not be getting the nutrition that she needs. And this has a snowball effect on things later on in the pregnancy as well as postpartum. Okay, like that poor nutrition can lead to poor growth of her developing baby. It can lead to poor blood flow through her placenta. It certainly increases her risk for preeclampsia, which can have very untoward effects on both the baby and the mom. It certainly increases her risk for depression, anxiety, and really poor bonding, right, during the pregnancy and beyond. And these are very, very complex issues mental health is just as important as that physical health. And I think it's incumbent on us as you know clinicians in women's health that we understand all of this and that we understand what it takes to treat these women and to make sure that they feel comfortable with the treatment. And that's sometimes the rub, right? Because everybody is treating these things a little bit differently. And so a lot of times we have to reach out to our neurologist for help or our perinatologist for help. And there's a lot still that we don't understand about migraines that I think is very important if we're going to improve maternal and fetal outcomes for these pregnant moms to be.
That's very unique, and I really appreciate how committed you guys are to your specialty and to your patients, and thank you everyone for that. And I think as like a natural segue now, though, I mean, one of the things that we always think about pregnancy is such a complicated time, right? And you add on migraine, and it just adds to the burden. What's the approach to treatment? How do we even personalize that treatment?
Yeah, that's a challenge. I would have to say that that conversation in my practice usually starts off with education because most women want to avoid treatment during pregnancy because there's a perception that the treatments may affect the baby and affect mom. So I usually start off with education on surrounding what can happen if you don't treat. And I start off with, okay, here's the first trimester. Let's start here. If you're having worsening migraine with or without aura in that first trimester, which is very likely to happen if you have a history of migraine, especially, our Danish colleagues put out a study that may be at higher risk for miscarriage. And so I tell them that, okay, first trimester, we really have to be careful to get things under control. There may be a higher risk of miscarriage. Second trimester, what happens if migraine is out of control? Well, I've seen in my practice the blood pressure starts creeping up. We see that hypertensive disorders and preeclampsia risks go higher as we go from the second to the third trimester. And that's associated with low birth weight for the baby. So these are some of the risks that we have to worry about if you don't seek treatment for migraine. And now the next thing I usually segue into, what does treatment mean? A lot of people are under the impression that they only need as needed treatment. But most of the people in my practice, I have them on preventive treatment and as needed treatment. Prevention may look like a nutraceutical, like magnesium or riboflavin. It may look like a mainstream medication, like amlodipine, just as an example. Or it may look like a device or neuromodulation. So if someone is having 4 or more headache days a month, I'm really considering a preventive treatment for them based on Neurology Headache Society guidelines. As far as needed treatments go, I would say all of my patients always have an emergency treatment, and that's usually looking like, an acetaminophen, metoclopramide, and beyond. Triptans have been deemed pretty safe during pregnancy based on large population data from Europe. And then, of course, neuromodulation and non-pharmaceutical things come into play also. But that's kind of how that first visit goes when we're evaluating. How about you, Jolene? What do you do?
Yes, Dean, you hit on a lot of the same things. And I do want to stress, first and foremost, I think even before talking about treatment is recognition. And for some women, they come to me and they don't even consider migraine in their medical history because they feel like there's nothing that can be done with it in pregnancy. So, addressing and recognizing that their migraine is an issue and figuring out how it is in terms of their symptoms are important. I also want to stress that it's also important to assess for kind of red flags or warning signs that would make us worried about things like preeclampsia or stroke, which would be kind of dangerous to miss and would alter the treatment discussion. So having said that, for me, most of the time as an MFM consultant, I spent my time discussing the safety of these prevented medications that Deena you have recommended, or that the patient, for example, the patient will come to me and say, the neurologist is recommending I take this preventive medication. Is it safe for the baby? Um, and so that's when we have kind of the shared decision making discussion, and we balance out the risks and benefits. And if it's not considered a first line medication, is the patient comfortable with the potential risks? As with many medications, avoiding exposures with uncertain risk may be advised. And also, depending on the medication, we may need to alter their pregnancy. So, for example, we may need to look closer for fetal birth defects, or we may need to follow the fetal for growth restriction. So that's kind of where my part in this treatment is at. And it is my experience though that most women try to avoid any unnecessary exposures when it comes to medications. But when that burden of the disease is so high, they are often left without a choice. And I think they do find some comfort in knowing that they can take this medication and there is a plan for them to be followed during pregnancy. And on the flip side, for those that do not prefer medications, they may do non pharmaceutical interventions, and sometimes patients will do both.
One non-pharmaceutical, I shouldn't say non-pharmaceutical, but non-medication approach that I failed to mention are nerve blocks, which are injections of anesthetic medication around the head, and trigger point injections within the trapezius. Those are pretty popular in my practice. And I would say I have many pregnant patients who come in every 4 to 6 weeks for those injections for prevention. And more evidence is coming out that botulinum toxin A may be another procedural approach that can be really helpful for the prevention of migraine. It's administered every 12 weeks, and the injections are a series of 35 to 40 injections, depending on which part of the protocol one's doing. It's called the preempt protocol. I use an acupuncture sized needle, and we do small injections along the forehead, the sides of the head, the back of the head, the upper neck, and the shoulders. And if the whole range of injections is done, I've seen that as an excellent approach to migraine prevention in people in pregnancy. So that's another approach that I've adopted more and more. And I'm usually pretty scared of using approaches during pregnancy. I'm kind of a chicken. But now that we're getting more and more evidence about the procedural approaches, non-medication approaches, and it's been really helpful incorporating those two procedures in my practice.
Yeah. I agree with you, Dana.
Yeah, I'm so glad you mentioned that, Dina, because there are so many times where patients come in who have been having Botox and they're so scared to continue with their current regimen, whether it be Botox injections or other medication. And so we do need alternatives for these women, for the prevention that we are all talking about. We need an action plan for these women that respects their wishes to avoid medication if they want. And I think it's important to provide different options for them. It shouldn't be a one size fits all, and they shouldn't have to be a purist about any of this when it comes to their decision making. And because at the end of the day, it's their body, it's their decision, it's their pregnancy, and we have to work with the patient and obviously with specialists like the two of you.
Can I then ask each of you, if that's okay, what are your two or three top favorite preventives or treatments? Because I know I have my favorites for pregnancy, and I'm just what do you suggest?
So generally, I start with magnesium as the first line. And if that doesn't work, then this is where we get the neurologist involved because we um, we need their expertise to help in terms of preventative. But then I would generally recommend a calcium channel blocker as my next go to. And then once it gets past that, I will, like I said, rely on the neurologist.
Yeah, I agree with you, Jolene. And part of the problem when you get deeper into some of those other medications is that as OBs, we're not aware if there are any protocols that we should be following if you're starting any of those medications. So it does give us peace of mind to consult a headache specialist who may be aware of all of these protocols that may or may not be present. Sometimes you don't know what you don't know, and to be fair to the patient, I think it's important to try and provide an expert like Dina, if for those cases where they're either not willing to take medication or their current medications are not working.
Absolutely.
That's really helpful to know.
Not so many of us get a chance to have that type of interaction with our OBGYN. And so I really appreciate that. So I really want to know about this paper that you guys all co-authored on neuromodulation, speaking about non pharmacologic treatments. Let's talk a little bit about that. What is neuromodulation and how is it applied to migraine?
We'll defer to Dina.
I can definitely start off this conversation about neuromodulation. I've been doing studies on neuromodulation for almost 10 years now. And the reason that I got into it was by chance, actually. I used to work in an academic setting, and there were a couple of headache specialists in the department. And my division chief said, I don't want to do neuromodulation, too complicated. Can you take all those trials? And I was like, well, I don't know anything about neuromodulation either. But I'm so glad that I was kind of asked to do that part of the clinical trials because it is something that patients have frequently asked me about after surfing social media. And it has been really helpful for the women who I see who don't want to be on an oral medication or a pharmaceutical during pregnancy. Neuromodulation and the paper that we is called Stimulating Discussion: Neuromodulation for Migraine in Pregnancy. It was published in Current Opinion in Obstetrics and Gynecology, and Jolene is our senior author on the paper, and it's really highlights the FDA cleared devices that have been looked at and approved have been cleared specifically for migraine prevention and as needed treatment. Neuromodulation is just a fancy word for a device that works at any different part of the nervous system to make it act differently. In the migraine space, we have 5 devices. I would have to say the 2 most common that I use in my practice are the remote electrical neuromodulation device, which is a really interesting armband that stimulates the pain fibers within the arm and turns off the pain circuit that goes up into the brainstem. It's FDA cleared in pediatrics, adolescents, and adults, and is worn every other day for prevention for 40 minutes each time, and then worn as needed for 40 minutes because it's something that is controlled with a smartphone, and it has an app that you can download and adjust the stimulation to what's comfortable. There's also cognitive behavioral therapy on the app and other psychological approaches as a part of their pain treatment. So that's one example. The other, and for that particular treatment, you do need a prescription. For the other, another option that patients have really liked in my practice is external trigeminal nerve stimulation. And this is a stimulator. It feels like kind of a vibration that sticks to the forehead with an adhesive, and it stimulates the supraorbital supratrochlear nerves within the forehead. And it's directly stimulating the nerves that are directly in the migraine pathway to turn off that pain signal. And this one's over the counter, and it is cleared for prevention and as needed treatment too. It's worn every day for 20 minutes for prevention, and it's worn for 1 hour for as needed treatment. And we specifically highlight these devices in the paper, and we can always link the paper to read about all the devices that are available to our audience, but we discuss these specifically because they are underused in practice. Oftentimes, even among neurologists, uh, they're not frequently used. We forget about them. We don't have enough education on them, or they may be cost prohibitive for patients. They are starting to get some coverage by insurance, but it's still early in that process. So cost can be an issue, but very popular among our pregnant population.
Absolutely. And so kind of what was the impetus for you to start educating your patients about these devices? Was it actually kind of seeing the level of evidence and the convenience for patients? Because I really like when you mentioned the over the counter device. It seems like That's something very simple to recommend to a patient, but I think you sound like you're more geared towards having something like evidence-based.
Absolutely. Two devices I mentioned and have been studied in randomized sham controlled trials that were pretty robust. I did work on the acute treatment trial for external trigeminal nerve stimulation, and we had around 300 to 400 participants in that. And so, in addition to the clinical trials that were done, I had previously put out a study looking at, okay, how often are people using non-pharmaceutical approaches in general for the treatment of migraine specifically? We found that up to 82% of people are using non-pharmaceutical approaches, and only around 43% of people even talk about it with us, their clinicians. And so I started asking people because it's important to them. And that's another reason that I've been recommending it and asking them if they're interested because especially within the pregnant population or other, for example, an adolescent population or somebody who is already on a lot of medication or has a number of medical conditions, they really want to be told about non-pharmaceutical approaches. That's what I've observed in my practice.
Is it the same in the OBGYN practice? Do you consider neuromodulation to be safe in pregnancy? And or, what are the gaps that currently exist in that research?
I there's no reason to think that it's not safe, right?
Got it.
There's no direct, yeah, there's no direct effect on the baby. There's no direct effect on the placenta. You're talking about nerve stimulation in the head, and really if you think about it, from a pathophysiological standpoint, there's really no contraindication to it, when you're pregnant, and certainly not treating the migraine is much worse, right? For all of the reasons that we cited earlier in this discussion. So for us, there would be no reason that I would not recommend this to a patient. I think the big issue is that um, most clinicians are not even aware of this, right? I mean, I know I had no idea about this until I joined this team, and so it's hard when you have no knowledge of something and a patient asks you about it for you to give a good opinion, right? Because it's going to take time for you to research it. And if there's not a lot of research out there, you may be a little bit hesitant to actually tell the patient that it's okay to use. And so I think it's incumbent to educate not only pregnant women, but also clinicians who treat pregnant women about this. I mean, I will tell you probably 99% of obstetricians don't even know what neuromodulation is. I would guess that the great majority of perinatologists uh, fall into that same category. And Dina would know better, but there are many neurologists who are not even aware of this. I mean, when I have patients and I suggest this and they go back to their neurologist, the neurologist has no idea what they're talking about. So there's really a gap um, in the training of medical personnel, right? This is not something that you learn about in residency. It's something that like your career as a physician is always ever changing and always educational, right? There are new things that we are learning every single day, and it's incumbent on all of us who are treating pregnant women to sort of keep up with all of this. Because there's nothing worse than when a patient asks you your opinion on something and you don't even know what they're talking about, right? You kind of feel like, geez, I've sort of failed the patient here. How can I make this up to her? How can I improve her outcome? But then again, we're under time constraints also, right? Like trying to educate ourselves about this without any formal lecture series about it. It's very hard to do the research on this. So it's wonderful to have people like Dina who are aware of this. Unfortunately, not all communities have headache specialists. There's a lack of obstetricians, there's a lack of neurologists, and there certainly is a lack of headache specialists.
It's also helpful, I think, to mention, and I forgot to mention this earlier, is people always ask me, whether they're clinicians or patients, what are the side effects? So I can comment on the two that I mentioned, just because those are the two I predominantly use in my practice. Is with the REN device, you control the stimulation, the armband, between 0 and 100. If the stimulation, you scale it too high, it can be painful and it can cause the muscle to twitch. That's the only side effect I've seen in my practice since it's been FDA cleared. With the external trigeminal nerve stimulation device, the big things I've seen is when you're wearing the device, since we're stimulating nerves, it can be you can feel a tingling sensation. In some cases, if the frequency is too high, it can become painful, especially if the person with migraine has allodynia, which is when things become painful to touch where it shouldn't be. And so pain, if stimulation is too high, is one of the potential side effects of neuromodulation. That's just a general comment. But apart from that, as Michelle was saying, not getting absorbed into the body, not interfering with other medications or treatments or conditions that the patient has. And so that's a big thing that I have to emphasize to clinicians and to patients, that it's a relatively safe approach.
So it
And I
sounds
would
like
like oh, go on. Go on.
so it's
I
not
was just gonna say, Jolene, you agree that, like, using neuromodulation along with medication is sometimes more optimal for patients. Like I said earlier, they don't have to be a purist about that, and you probably can speak more about that than me.
Agreed. And you bring up a great point that you can use it in combination with both. And I do think it gives women options, right? And I think that's the important when we are counseling patients, that you're providing a variety of options for them to choose from and what makes sense with what they feel they want to do. And so neuromodulation does have a very favorable safety profile. And I think a lot of patients like the idea that there is no effect or placental transfer that they have to worry about when talking about medications. So,
absolutely. So it sounds like neuromodulation is well studied. Obviously, we have devices that are FDA cleared, but the main barrier is that clinicians don't yet have awareness, and also there's so much education that needs to be disseminated on the impact of neuromodulation, the side effect profile, the combination of neuromodulation with treatment approaches for migraine and pregnancy. And on that note, do you guys have any kind of current things that you're working on to establish more evidence for this? Can you talk a little bit about um, give our listeners a preview of like what's potentially up and coming in terms of studies and investigation here?
The biggest goal, I think, with neuromodulation in general is to continue to study the devices in compromised populations. And, we have to study the device in children, adolescents, folks who have or using other devices. The REN device recently put out a paper showing how it may or and may not interact with the diabetes monitoring device that's implanted. Really looking at those special populations is so important, as there are more treatments rolling out, there are more devices rolling out across the board in different medical specialties. I think the most exciting thing that the three of us have been working on is the migraine pregnancy registry with the external trigeminal nerve stimulation device. All three of us have been working on that for a couple of years now and really working hard we shaped the protocol and actively recruiting and monitoring that closely. So that's been really exciting. What's been your experience, Jolene and Michelle?
I mean, I have to say for a registry, it's truly one of a kind. I think what we have designed in that we follow patients who have migraines all throughout their pregnancy, even 3 months up leading before they got pregnant, through each trimester, and then again postpartum. So it's very comprehensive. Hence, it is taking us some time to recruit. But I find that what we are going to get from this registry, not just only about the way the migraines impact them during the pregnancy, but how it may affect bonding in the postpartum. I'm really excited to see what we can learn from this to help our patients.
Yeah, I agree. It's very robust. The amount of information that we're getting from this is just incredible. We're really hoping to impact a clinician's approach to treating migraines during pregnancy, and not only that, but just sort of opening their eyes to the ramifications of not treating. Right. And to be in this registry, you don't have to be on any medication, you don't have to be using any device. This is simply a registry where we are asking patients, hey, what's going on during your pregnancy? What are you experiencing? What medically is happening to you? What effects are occurring with your developing baby? And I think that when we publish, there's going to be a lot of new information that we're going to be able to present to the clinicians, not only in this country, but honestly worldwide. I think that it's going to be a very, very impactful study when we are all finished.
Quick question. So how does the patient find this registry, like who is not in your care?
This registry is listed on clinicaltrials.gov. It's called External Trigeminal Nerve Stimulation for Migraine Treatment in Pregnancy. And, all patients are welcome. Anyone who's pregnant and experiencing migraine is welcome to join the study.
That's amazing. So thank you guys so much for sharing your career journeys on this podcast today. Information about why migraines are so important to manage in pregnancy, teaching us and giving us a little bit of a preview of why neuromodulation is an important current approach to managing women with migraines. And I think that to your points, and you made some great points, like with adequate education, innovation, and research, we can really start to hone in on further personalizing treatment for women with migraines. And for that, I thank you for your life's work, and I thank you for being a part of this podcast today.
Thank you.
Thank you for having us.
To our listeners around the world, thanks for joining us today. Tune in as we continue our journey to amplify the voices of women leaders in healthcare. Hear From Her is brought to you by Medscape Education. Please subscribe to Hear From Her on your preferred podcast channel and follow us on LinkedIn. Until next time, remember to lift as you rise.